Hello everyone, my name is John Pilla and today's presentation is on value-based healthcare, Australian developments and opportunities for public hospitals. First, I'd like to acknowledge that I'm delivering this presentation from the lands of the Kaurna people, and I also acknowledge the traditional owners of the various lands on which you live and work today. I also acknowledge the co-authors, Catherine, Rick and Angeline, who are all affiliated with GENI, Guidelines and Economists Network International. Purpose of the presentation, or of our work, because this is a presentation of our work in progress, has been to identify opportunities for the Australian public hospital system to further advance its endeavours so that value underpins healthcare policy in the service system. Our approach has been simple. It's based upon a systematic review of literature to identify current state and then assess this current state against the Porter's framework of value-based healthcare. The limitations of the study is that it's based upon publicly available information, and it's likely that some jurisdictions are doing more than what we've been able to ascertain. Porter's framework provides a useful way at looking at the concept of value-based healthcare. However, often it tends to be solutions orientated and solutions that reflect problems in the US healthcare system. So it is important to look beyond the detail of Porter's framework and focus on the underlying principles. An alternative framework is that advanced by Elizabeth Teisberg. There is a significant degree of overlap between these two. The Teisberg framework defined by key principles rather than solutions. But what is value-based healthcare? It is a concept that takes many forms, but loosely it is about increasing the value of a hospital system, value that a hospital system generates for patients. When it comes to the reimbursement aspect of value-based healthcare, it is not dissimilar to cost effectiveness, but there are important differences. One could easily start with New South Wales health definition, which is that value-based healthcare continually strives to deliver care that improves health outcomes that matter for patients, that improves the patient experience, and that increases the efficiency and effectiveness of care. The NHRA, or the National Health Reform Agreement, roadmap of 2021 is entirely consistent with value-based healthcare principles. If the health ministers succeed with its implementation, then Australia will have made a quantum leap forward. Therefore, why this study? Simply because national reform has not always proven to be nimble, and in its implementation, often compromised. Therefore, we set out to identify whether there are actions that could be taken in the immediate future and that would make a difference. And our journey started with looking at the current state using Porter's framework. Our assessment is a relative assessment. We're not grading jurisdictions, but we look at where they are at relative to Porter's framework. And there are 7 dimensions that focus on integrated practice, outcome measurement, cost management measurement, value-based reimbursement, regional systems integration, geography of care, and information technology. And you will see from our current state assessment that it's largely a sea of green and yellow. But you will also see, however, some ambivalence in our assessments. All jurisdictions have strengths in place and are pursuing innovation that are consistent with value-based healthcare. The gap clearly is in health outcomes. While all jurisdictions have been rated as having made significant advancements in areas of systems integration and cost measurement, we've included some yellow shading, meaning there's still a lot more that can be done. Similarly, we've rated value-based reimbursement as being at a state of modest development, as ABF makes a contribution to value-based reimbursement, and because of recent changes to the addendum of the National Health Reform Agreement. I will not dwell on this assessment other than to say that our hospital system has many of the fundamentals, but there are many opportunities. So what are the specific strengths and opportunities? The national level, fundamental building blocks in place. The reform agreement, its addendum, and the roadmap. Institutions such as IHACPA, MSAC, PBHC, Safety and Quality Commission, all have a pivotal role in the value-based healthcare system. But there are gaps, and the two that I'd like to focus on, first of all, is that there are perverse incentives and barriers that arise from the fact that we have different funding regimes and rules across the different sectors: hospital, aged care, primary care, disability care, social care. This is evidenced, for example, in the most recent Royal Commission review work. At the state level, there's clearly significant level of innovation that's going on in terms of models of care, being significant advances being made in terms of improving service linkages and service continuity. But there are also gaps. And the two that I like to focus on are the continual struggle that states have to move from innovation to mainstreaming proven models of care. And related to that, significant clinical variation, as evidenced by a number of studies over at least 20 years. And then secondly, the erosion of activity-based management capability. ABF started out on its journey in the 1990s, really on an activity-based management platform. And we've seen waves of improvement and then downward spirals. And could we again yet be on one of those downward spirals, moving away from activity-based management? In conclusion, we have strong foundations that support a value-based healthcare system. Value-based reimbursement is essential, but on its own is insufficient. There is a need to scale up and mainstream proven innovation, minimize low-value care, a greater focus on cost-effective models of care. We need to remove barriers that create silos across different care sectors and even across different clinical areas. And we need to allow greater flexibility that promotes innovation at a local level. We need to include in our reimbursement models, complementary models that ensure service integration and continuity of care, such as bundled payments, and reimbursement models that promote outcomes, such as pay-for-performance models. The literature struggles, however, to demonstrate the conclusive benefits of bundled payment models, pay-for-performance models, and capitation models. They tend to be small to moderate. This is not an argument against pursuing these types of models, but it reinforces that funding reform alone will not achieve the desired outcome of having a value-based healthcare system. So what do we suggest could be done as achievable next steps? What can be done in the immediate future? First of all, a national approach. How often is this talked about? The roadmap goes partway to our first suggestion, but it does not directly deal with the reform barriers that are a function of the different funding regimes across the different care sectors, the different funding rules, funding methods, and funding models across hospital, aged, primary care, disability care, and social care. That clearly create diverse incentives the way in which the system operates and create barriers to seamless healthcare for patients. Bundled payments. They can be introduced for surgery by bundling pre and post-operative outpatient activity in the price. And there are many DRGs with a predictable post-acute care pathway. This is within our reach. It has already been proven within at least one state. Therefore, it can be done. We acknowledge IHACPA's concern around patient linkages and having a unique patient identifier, but there are strategies within our grasp to deal with that. Growth caps. This will be controversial, but is a valid strategy, particularly given the abundance of evidence supporting the need to curb low-value care. Fourthly, pay-for-performance models. This needs to operate at two levels. At the macro level, where performance targets set at either at an LHN level or state level. This will be controversial given the Commonwealth's role in this area. And at micro level, there are many possibilities. We could link funding of specific clinical technologies or clinical interventions to the application of clinical guidelines, or even link them to patient outcomes, link funding to demonstrable patient outcomes. But there are also a range of other possibilities. But pay-for-performance models need to operate at the system level as well as the micro level. Cost effectiveness. The addendum set the precedent to fund new high-cost technologies based upon their proven cost-effectiveness. This means we're now in a position to extend this to existing clinical technologies. It is a small step to apply this precedent to existing high technologies, not just to new technologies. And finally, the carbon solution. We can extend the flexibility we've seen during COVID that allows how hospitals operate innovatively and flexibly. We need to introduce some form of NWAR equivalent unit or an NWAR credit, the carbon credit scheme. We set out to demonstrate there are many opportunities within our immediate grasp and hope that we've convinced you of this. Thank you for your time.